It's an honor to be here. Certainly, this area that is scleroderma and scleroderma-associated pulmonary hypertension is an area of great clinical interest. From my standpoint, I see many patients with this on the clinical side. A lot of my research is actually been dedicated to this coming up, or going over the last number of years. I've been honored to have received research awards from the Scleroderma Foundation, and was very honored when they asked me to serve on their local advisory board, and that's something that really it's been a great thing to be more involved with, an area again of certain clinical passion and research passion from my standpoint, and it's also a great honor to be able to work with Dr. Kolvenbach, Dr. Fisher on the clinical side and on the research side. And some of the things that I'll talk about today are work that that Dr. Fisher and myself are very involved with from the standpoint of PH and scleroderma. So certainly I want to make this interactive. I was noting that Dr. Kolvenbach was taking questions during. If I say something that really sort of ignites a question, feel free to raise your hand to interrupt me. I'll kind of back up. There's no reason I need to get through all of these slides. I kind of put forward things that I thought would be of interest, things that would be of certainly clinical relevance, possible research relevance. But if I'm talking about something that A, isn't making perfect sense, let me know. Or something you have a question about. Let's see, my wife is actually out of town, took my eldest with me, but left me with my two middle children who are in the back. I'm going to, I'm going to sort of survey how I'm doing on this talk in terms of interest. They each have a Kindle in front of them, and if they're staring at their Kindle continuously, I know I've lost at least part of the audience here. And so I'm going to turn around and sort of see how things are going, intermittently check on them. My middle one, I was able to give the Tom Petty Lung Conference, which is a similar patient-driven conference a couple weeks ago. Victoria, my middle child, back there actually got to, I don't know if the honor of attending that twice. So she's heard various of this talk twice. I'm going to have her give it the third time here coming forward here. So we'll see how this comes along. So Tori, you might particularly want to pay attention here. So what am I charged with doing? This is pulmonary arterial hypertension and scleroderma. Let me just mention really briefly. So one of the things that I do here at the university is oversee our Center for Lungs and Breathing, of which Dr. Kolvenbach, Dr. Fisher are both an important part of. That center is comprised of what we call 7 pillars, okay, which run the gamut from lung transplantation to thoracic malignancies to advanced lung disease and pulmonary vascular disease, allergy, asthma, inflammatory disease, complex airway, and sleep medicine. What we're going to be talking about today, Dr. Fisher has this part, the advanced lung disease portion. I messed up that circle here a little bit. And I'm going to go over pulmonary vascular disease. Okay, so these are important components of what we're doing here at the university, really trying to centralize, standardize, and kind of put a multidisciplinary arm on these disease states, realizing that in diseases like scleroderma, the one we're talking about today, can be multi-system, hit many aspects of normal physiology, but the lung and the lung vasculature are an incredibly important part of that. And so having teams dedicated specifically to those areas who then interact and crosstalk in a meaningful way, I think is going to be important in terms of management and really the direction we should all be moving. And so this is our pulmonary vascular disease program. Again, so within these pillars, this is a specific pillar where we deal with pulmonary arterial hypertension, which we're going to talk about today, high altitude pulmonary embolism, hypoxic lung disease, HHT. But our focus today is going to be PAH because this is what can occur in scleroderma. It is an important, very clinically important part of what can occur within the disease state of scleroderma. And I'll try to touch back on that Raynaud's pulmonary vascular linkage here before. I had a picture of that in and I took it out. I was like, oh, that's maybe too far off topic. Now I see I should have left that picture in. But I'll circle back around to this. So to start off, let's kind of all bring us to the same place. All right. So we're going to do a little bit of lung physiology. This is going to be lungs 101, if you will. If I am saying things that you already know in detail, you can say, hey, I understand that, move on, let's get on to the abnormal physiology. But I think to understand what's happening within the pulmonary vasculature in particular and the lung specifically, it may be worth starting about that we're all in the same place. So what do our lungs do? A fairly basic question, but But I think important, again, to understand, hopefully this is a little hard to see, but you can kind of get the general trend of it here. So the lungs can really kind of be broken into really two big areas in terms of their function. That is the conducting portion of it. So here if we go from trachea to the left main bronchus, the left upper lobe, lingula, left lower lobe. Okay, so this is really where we're conducting air in and out. So we take a breath in, air entering via our trachea to this. But the role for this, and what really, again, the beauty of the lung, is to get down to this gas exchange portion, or the respiratory portion of the lung. And these are our alveoli, okay? And so this is, you would need a microscope to see this. These are these little air sacs called alveoli where gas exchange occurs, okay? So we're really moving air. We're moving air down. We're moving, carbon dioxide back up out as we respire. But the goal is really to engage these alveoli down here, these air sacs, which are going to be a key part. So each of these has a very thin membrane. They let oxygen and carbon dioxide, other gases with them, but those being the predominant ones, transport back across these two areas. But another important part of this circuit is the heart, okay? So again, now heart physiology 101, and how do these two entities interact? We'll get here in a minute. The heart, of course, 4 chambers. The chambers that I am particularly most interested in are the right side, and this is how specialized we are now coming in medicine. I am a right heart doctor. I ignore the left side, or not entirely. I pay some attention to it. But most of my focus, most of my research is focused on the right heart. I walk around teaching the residents that the right ventricle is actually the more interesting ventricle between the two, okay? Right. In fact, my mantra is, forget the eyes, the right ventricle is the window to your soul, all right? You can tell how an individual is doing from an ICU standpoint, which is where I spend some of my time, from the pulmonary hypertension standpoint, by looking at what their right ventricle is doing, all right? That is a critical aspect in terms of how patients live, thrive, and survive, especially if pulmonary hypertension is going on. So we have right atrium, right ventricle, left atrium, left ventricle. We're going to ignore these today. They are important. I just, you kind of need them. But the right side is where our focus is going to be, okay? And so how do we connect these entities? This is really where I am talking today. This is the pulmonary vascular bed. So this is a beautiful and elegant system, if you will. We kind of covered it up here. But so these are the pulmonary arteries, all right? This is our connection now between the right heart and the lungs. And this is what goes awry in pulmonary hypertension, pulmonary arterial hypertension, if you will. This is essentially high pressure of these vessels here in the lungs. So if we can imagine our right heart squeezing blood up into these vessels now taking it down to those air sacs, that alveoli I was showing you before, a pulmonary artery in red, a pulmonary artery in blue, a pulmonary vein returning oxygenated blood in red here. And so this is where, again, this gas exchange has to occur. You can have these air sacs, but if your vessels running to them and from them are not functioning correctly, you cannot transport that oxygenated blood off to the left heart. You cannot bring deoxygenated blood from the right heart to it. So it's this beautiful interaction of right heart, lung alveoli, and then these vessels that is so critically important to our normal functioning well-being, if you will. And it's here where things start to fall awry in patients that have pulmonary arterial hypertension, and it is here in scleroderma where vessels are at risk. And so even though we talk about the pulmonary arteries, these large vessels here, it's really at the very small, what we call pre-capillary. So right before these right in here, these very small vessels in here are capillary beds. So right in here is where disease can occur from a scleroderma standpoint. And let me just circle back to Raynaud's, that vasculopathy that can occur in the hands, to some degree can occur in the vessels. Now, it's not exactly the same. It's not totally analogous, but it is one of our clues as to what's happening in the pulmonary vascular bed, because we see patients with other forms of pulmonary arterial hypertension who are also at increased risk of Raynaud's. They don't have scleroderma, but they have Raynaud's, and it's been a big clue to us for some time now that the things that are happening within the peripheral vasculature of the hands can happen within the vasculature of the lungs as well. So let's talk a little bit about the pulmonary vascular bed. This is really, in my estimation, this is a beautiful system, an elegant system. It's one of the things that actually the normal functioning of the pulmonary vascular bed the right heart, and the lungs. It was one of the things that drew me to pulmonary, and then as a specialty, and then I went on and actually then trained in cardiology, so I could do both of these things, look at both of these at the same time. This is a high capacitance, low resistance system, okay? Meaning that if your pulmonary vascular bed is working correctly, you can put a ton of blood, your entire blood flow. You can escalate it if you're, exerting yourself, in the Tour de France, if you're, cranking up one of the Swiss Alps, one of the French Alps, something along those lines. You can take your blood flow, your cardiac output, from a normal 5 to 6 liters per minute to 20 to 30, some highly conditioned athletes, to 40 liters per minute. But the pressure, even though all that flow is increased, doesn't go with it. Somehow, and I'll tell you how here momentarily, the pressure remains low. And this occurs through, and again, so fourfold increases in change in flow without changes in pressure. And this occurs through a really elegant system of both vasodilatation, so the vessels that you have relax and open up, and then recruitment. Vessels that you're not using in the periphery of your lung are recruited to accept this flow without a rise in pressure. But of course, this system, like all systems in our body, can be perturbed through various disease states, if you will. And so here's an example. This is a CAT scan. This is basically a pneumonia, is what we see right here. All right. So this is an area of the lung that's now become infected. And our lung vasculature is pretty smart, all right? So I tell I have an inherent bias towards this, but I tell our residents that it's much smarter than the kidney. The lungs are smarter than the kidneys. The kidneys get confused by all sorts of things, but the lungs are pretty smart. The lungs know that if you have a big pneumonia sitting up there, you would just assume not send your blood up to that area, okay? You would like to send your blood to all these kind of black areas, which is our functioning lung right here, and stay away from this area of infection, all right? So your lungs, seeing that, sensing something's amiss with the lung parenchyma there, the lung vessels start to shut down. They basically increase a vasoconstrictor called endothelin. They down-regulate a vasodilator called nitric oxide, all with the goal of making sure that blood doesn't flow to that area to improve something we call VQ matching, ventilation perfusion matching. You want, your body wants, your lungs want your blood to go to the parts of your area that function and stay away from areas that don't. Other disease states, however, can confuse this. So this is emphysema. This is basically COPD. A lot of those lung alveoli sacs have been destroyed by smoke inhalation over years. And this gets confusing for the lungs because now there's tons of the lung that don't work. And now they got to try to sort out areas that they could, in fact, send blood to. And as lots of areas start to vasoconstrict, pressures can begin to rise. And this is what we worry about in pulmonary arterial hypertension, all right? So now I'm going to the microscopic level. This is that very small pulmonary artery coming just out to the alveoli. The alveoli we start to see out here and here. So those lung vessels are coming out, and we see this very abnormal proliferation of cells within the pre-capillary pulmonary arteries, all right? So this is something very different than this, but something that we see in scleroderma-associated pulmonary arterial hypertension, and in fact, other forms of pulmonary arterial hypertension. I'll show you a list of the diseases that can in fact do this. But this is referred to as the plexiform lesion. This is what it should look like. There should be one cell layer thin going through here, letting blood move. And here we see a branch point right here. And here we see this very abnormal proliferation of cells. Here we see another abnormal proliferation of cells, which effectively block off that pre-capillary pulmonary artery. And that is what is occurring in pulmonary arterial hypertension. That is what is occurring in scleroderma. And a variation of something like this sort of onion skinning effect, we can see in Raynaud's, but there's something different about Raynaud's in pulmonary arterial hypertension, and that Raynaud's can be much more intermittent in terms of its vasoconstriction process. And I'll just mention here, so since we're in Colorado, anyone who sat on the top of certainly Mount Everest, but also, if you sat on the top of Long's Peak for long enough, you would develop a form of pulmonary hypertension. The reason being, again, your oxygen level is now globally low. Your pulmonary arteries are vasoconstricting, trying to find a part of the lung that works, but realizing the entire lung is experiencing hypoxia, so all the pulmonary vascular bed is now starting to vasoconstrict. And over just a couple of days, you will start to remodel your pulmonary vascular bed and develop a form of pulmonary hypertension. This one, however, tends to be, this one is, if you descend again, that pressures would come back to normal as your oxygen ascends. This one, if the pneumonia clears, those pressures can drop. This one, more difficult to deal with because of COPD. And this one is what we're trying to figure out. How can we focus in, how do we get this thing to go away, this plexiform lesion, or stop it from forming? This is an area of active research right now. So how do we classify pulmonary hypertension? I threw up a variety of different variants here. This is the WHO current classification scheme. This is kind of a busy slide, but basically it breaks pulmonary hypertension into 5 different groups. So group 1, 2, 3, 4, 5. Group 1 is really what we're going to talk about today. Okay, this is where Scleroderma-associated pulmonary hypertension resides. Here we sort of type it under connective tissue disease-associated PH. But we look at these what other forms? There's idiopathic, there's heritable, a form of pulmonary hypertension that you can inherit from family members. There's drug and toxin induced. This used to be the phentermine, fenfluramine, the diet medications that cause this. Now this is predominantly meth. This is meth-induced pulmonary hypertension is what we see in my clinic. I almost see a new case of meth at least 1 to 2 per month was causing PH. And then there's the associated with connective tissue disease, HIV, portal pulmonary congenital heart, schistosomiasis. So a very disparate, if you will, wide-ranging group of diseases. Why in the world would we loop all of these together into one group, that is one category, pulmonary arterial hypertension? Well, the reason being, again, is this. All right, so all of those diseases, all of those WHO group 1 forms of pulmonary hypertension develop this plexiform lesion. Again, that branch point, abnormal proliferation of both endothelial cells. This is the cell that lines right here. Smooth muscle cell, the cell that's kind of next down. They really kind of go crazy. They proliferate. They block this vessel up. And the why, that's the million-dollar question. Why is that occurring? All right, because if we understood why it was occurring, we could figure out a way to shut it down. And we are, and I'll say up front, sort of as a spoiler, we are getting closer and closer to figuring this out. We are learning a ton about these lesions, about why they're forming. This is really, I think, where the excitement is coming from the treatment of PAH. And there's a lot of things to be excited about. We've made a lot of headway. But once we kind of figure this part out, I think we're going to really, we really have a chance to dramatically change the natural history of this disease state. And so here we see it over time. So this is a normal pre-capillary pulmonary. You can see really again how beautiful this is. One cell layer thick. As this disease begins to continue, we see proliferation. We see both the intima and media beginning to thicken up around it and ultimately block off. And interestingly, these blocks tend to occur right at or right after these branch points. We don't really understand why that is. There's all sorts of theories about shear stress. Part of what my lab was working on a long time was models of this, trying in a capillary tube to recapitulate this, try to figure out why it was occurring. But that is a truism of this disease, is it tend to occur within branch points. And so what happens here over time? So from a clinical standpoint, so here we see cardiac output, the amount of blood exiting your left heart, pulmonary artery pressure, what the pressures are, and then pulmonary vascular resistance, how hard it is for blood to move through this pulmonary vascular bed. Here we see functional class, New York Heart Association functional class, 1 being normal, like you can do anything you want from an exercise standpoint, feel fine, to as this disease begins to progress, we see cardiac output start to decrease, we see PA pressures begin to rise, pulmonary vascular resistance begin to rise, and we start moving through various forms of New York Heart Association functional classes, and then BNP, a biomarker, so one of the blood markers we formed for this. Eventually we get to this, again, remodeled form of the disease here. We can see cardiac output dropping off dramatically. PA pressures actually begin to fall because now the right ventricle just can't push against this severe pressure elevation, and then ultimately PVR, again, shooting up, moving into New York Heart Functional Class 4. And so this is the progression. A couple of things we're trying to figure out. If we get to here, how do we get rid of it? Here it's termed irreversible, but I think that's just our understanding of it now. I think if we figure out this proliferation, one of our goals is to reverse this. But how could we catch it earlier to keep it from getting to that point? That's one of the other big focuses in the treatment of pulmonary hypertension where we are right now. So our definition of this, our hemodynamic definition, to have a diagnosis of pulmonary hypertension, you have to have a mean pulmonary pressure of greater than 25 millimeters of mercury, all right? So this is mean pressure. So PA pressure is just like in your arm as a systolic pressure. a diastolic pressure, and then the mean is just the mean of those two numbers, okay? And so, to get to this, we do a heart cath. I'll talk about that here momentarily. That's the definition of pH. The definition of PAH, pulmonary arterial hypertension, is you have to have that plus the pressure on the left side of your heart needs to be normal, okay? So this pressure elevation on the right side cannot be due to a high pressure on the left side. So that's why we put this definition in for pulmonary arterial hypertension. And then more recently, we've included that you have to have a resistance of greater than 3 Wood units, which is a calculated number based in part off these two things and cardiac output. So how do we evaluate for this? Okay, so what is, when we see someone with a diagnosis or considering a diagnosis of PH, how do we pick this up? How do we hone in on it? This is, again, one of the big things that that we're in the process of doing is trying to get out to docs in the community, and in particular, scleroderma poses a specific opportunity for us to intervene earlier because we know, unlike a lot of those other forms of pulmonary hypertension, that people with scleroderma have an increased risk of developing this. And what is that risk? Depending on what you're looking at, anywhere from about a 5% to 20%, depending on the literature that we look at that, but probably somewhere around, if we took all comers, probably somewhere around a 10 to 50% increased risk. And so we know patients with scleroderma are at increased risk. One of our big focuses, one of my big focuses, Dr. Fisher's, Dr. Kolfmack's big focus, is make sure that docs out in the community who are taking care of patients with scleroderma are asking questions to try to hone in on catching this diagnosis early so we can intervene early. Because we have evidence that if we get on this, if we start treatment earlier, patients will do better over the long run. One of our ultimate goals is try to keep that proliferation from moving forward. So how do we get at this? Well, like all things in medicine, even though it's not the sexy part of what we do in medicine, it is probably the critical part of what we do in medicine, and that is taking a good history, okay? What is it? What are the symptoms that this progresses with? And this is, well, we know, again, people with scleroderma are at increased risk. The tricky part is some of the symptoms are very non-specific. I mean, they could be associated with a lot of different things, okay? So one of the classic symptoms we're looking for, what is your exercise tolerance? Are you able to do the things that you did a year ago? Can you do those normally? Can you go through the grocery store without problems? Can you walk up a flight of stairs without difficulty? If hiking is something you like to do, can you hike? Can you hike the same distance? And one of our challenges in pulmonary hypertension, not just in scleroderma but across the board, is that there's a tendency to think of other things, and that's understandable. There's other much more common causes of being dyspneic than pulmonary arterial hypertension, which is, in the grand scheme of all things in medicine, relatively rare. But when we know you have a defined risk for it, such as scleroderma, we really need to hone in on those questions and make sure, specifically that we answer that, is this a problem or not? Okay, so if we look again at all comers for pulmonary arterial hypertension, this is one of our great shame in this area is that in the 1980s we had a registry showing us how long it took from the onset of symptoms to the time of diagnosis of PAH. In the 1980s, it took about 2.5 years from the time symptoms began to the time we ended up with a diagnosis. And we said, well, that's terrible. I'm sure we are much better at this now. Usually, people show up and they say short of breath. They get called asthma. They get called, maybe there's a tobacco history that's due to COPD. Maybe it's just that you're getting a little older and your exercise tolerance is dropping off. Okay, these are the reasons that were put forward. So he said, well, I'm sure we're better at this now. So we re-looked at this survey in a bigger group in about 2010 to see how much better we were. And what we found was from the time of onset to the time of diagnosis, that is onset of symptoms, time of diagnosis, it took about 2.5 years. All right, so we had not moved the needle at all in this, 20 years plus since this had occurred. And so again, this has to be a big focus for us, going out and sort of saying, if your patients, certainly those with defined risk, start complaining of things like decreased exercise tolerance, feeling tired, unable to do some of the things that they used to do, don't just make the assumption that it's due to getting older, that it's asthma, which is frequently what this gets called, that it's something else along those lines. Take a look. And I think we're getting better at this in scleroderma for sure because we have such great rheumatologists who are really, again, sort of out there championing this. We have the Scleroderma Foundation who puts on things like this to sort of really help help get the word out that this is something we need to look forward to. So after history, so usually the history is shortness of breath, and let me just stop a minute for history. Also, as this disease progresses, we start seeing swelling. As the right heart fails, we see swelling. As it really progresses, you start seeing fainting or near fainting. But those, we don't want to wait till that point. We really want to start catching it early, all right? So then to exam, all right? So exam, we're listening to the lungs. The heart, of course, is a big portion of it. Trying to, again, hone in on things that show us either lung disease, underlying parenchymal lung disease, ILD, like Dr. Fisher will be talking about momentarily, or is it the right ventricle? And there are specific signs and symptoms on the RV, murmurs that we listen for, extra heart sounds that shouldn't be there, which I won't spend time talking about now unless we want to get into those. And I just want to mention this, though. All my patients, if you come to see me in clinic, I spend a lot of time looking at people's necks. I see a few people I recognize here in the audience who know that there's not a time. You don't come see me in clinic without me taking a look at the neck. And eventually, usually people either early up, they ask why, or they figured out at some point. What I'm looking for are these veins in the neck. This is the internal jugular vein, okay? And specifically, I'm looking for is there elevation of that vein. That's kind of a, if you will, a cheap right heart catheterization. It shows me pressures on the right side of the heart, and specifically, it shows me waves, specific waves that I can look at that tell me where those pressures might come from. And this is called jugular venous distension. And you usually do this at 45 degrees. And as the right heart begins to have harder time push against pressure, we'll see elevation of those veins. We'll see changes in the wedge. All right. So that's correct. So the lung exam, the heart exam, and looking for the JVD. There's other things we look for, of course, but these are things specific we hone in on for pulmonary arterial hypertension. Then we start our battery of tests, all right? And so again, if we are suspecting pulmonary hypertension as a cause, one of the first things we'll get to is lung function tests. So we kind of put you in a glass box, we pinch your nose shut, we have you blow into this machine for us. And what we see in terms of, this is basically you blowing in, or a patient blowing into the machine, depending on how these various airflows look, and what else might be, other trends we see in it, help us hone in on specific lung diseases. And then part of how you transport oxygen, something we call your diffusing capacity, we can measure that as well, will tell us again about potential disease in those very small pulmonary arteries. If you're not moving gases, that is carbon dioxide and CO2 in an appropriate way, we have a way of measuring that using basically carbon monoxide, a very small dose of that to look at it. Then we go to echo. That's one of our classic non-invasive studies, okay? And this is an algorithm that Dr. Fisher and I actually put together a number of years ago, published to sort of show, hey, in scleroderma, this is how we think patients should be screened. That is history, are you short of breath, lung functions to see if your lungs are functioning correctly, and then an echo. And this is the right side of the heart on echo. This is the right ventricle, right atrium, left atrium. This is a very abnormal echo, all right? So normally the right ventricle should be half the size of the left ventricle. This one is much more dilated. The right atrium should be about the same size as the left atrium. Here you can see the right atrium really kind of squishing the left atrium down here. And this is where, again, where we don't want to catch things. This is very severe or advanced pulmonary hypertension. We want to catch it earlier. We want to find it earlier so we can intervene earlier on. And then ultimately, what we think is very important, and this is all societies, this is us recommending this as well, all that deal with this, is a right heart catheterization to confirm or refute pressure elevation and then to point us towards appropriate treatment, okay? And so right heart catheterization is placement of the catheter down into the right atrium, into the right ventricle, up into the pulmonary arteries where it occludes this, and we can get a very specific measurement, an exact measurement of pressures. And echo is not echo gives us clues, but it's not an exact measurement. To make this diagnosis, we have to have a right heart cath to confirm the diagnosis and then to make appropriate assessments of treatments. And so this is one of the things that I wanted to make a point of, is that really the remarkable progression we've made in terms of taking care of this condition over the years. And so we started back in the 50s with no treatment. In the 70s, we had oxygen diuretics and digoxin, which we really aren't sure still to this day if it works well. In the 80s, we had this medication, epoprostenol, was started. And look where we are in 2016, okay? And this is not even mentioning the 6 other trials that we have ongoing right here now at the university in these specific areas, and a multitude of other studies going across the country, all now focused on different areas of treatment of PH. This has really been an explosion in our understanding of this disease and our explosion in our treatment of it. And now what we're looking at is how we can sort of start putting these together in an effective way. So new directions, and again, I think this is while this is a very serious disease to deal with, this is one of the conditions that really can increase the chance of mortality in patients with scleroderma associated, or patient with scleroderma. Again, our treatments for it have been really sort of have changed the paradigm in terms of how we manage it, have significantly improved outcomes and our ability to treat it, but we're really also now very excited about directions we're moving forward. Part of this is combination, all right? So now we can start putting some of these medications together in effective ways. Now, when you have like 14 different medicines to pick from, we can start moving them in different directions. We can actually start do treatment paradigms where we actually start drugs earlier. So historically what we've done is if we have a diagnosis of PH is we start one drug, we see how you do. If you're not doing that well, we start another drug, maybe a year later, 2 years later, still not doing that well, we add a third drug. Now our studies are moving towards we've got all these different medications. Why don't we start ones that work differently together right up front? So within a month or 2 months, we'll add one drug, a second drug. Now a study we're looking at adding a third drug. So I think this is really going to change, again, our approach to this disease state. But really, again, where I think most of our excitement is what is this, okay? Because all those drugs that I've showed you here, go back through this list, all of these actually work to relax the pulmonary vascular bed, to try to get blood to kind of slide through the holes that are still there, and to sort of improve how that function is going. But what we want to move to is, how do we change this? How do we get rid of this here at this point, okay? That's where our focus is, and we have at least, again, 3 studies coming down the pipeline now. We'll participate in a couple of these now here at the university, where we're actually looking to see if we can either stop this proliferation or maybe even more importantly, regress it, make it go back, get this to shrink around. Really, almost if you want to think about a cancer paradigm for this, if this is an abnormal growth phase, if these cells grow in an abnormal way, can we add a medication that makes them not just quit growing, but regress, but shrink back down again? And that's really, again, where our focus is right now. And it's very exciting, an exciting time to be a part of this research because it's moving so quickly right now at this juncture. So let me just say a couple words about exercise and pH, because I want to get on to questions. Things that we, for a long time we used to say if you had pulmonary hypertension, we didn't think exercise was a great idea, put too much of a strain on your heart. We've actually kind of completely reversed around that. So things that you can do for yourself if you have this diagnosis. We do think an exercise program is important. Why exercise is important for really anyone. It's important, particularly in pH, I think, to improve our muscle function and improve how you otherwise are sort of living and thriving here at this point. And so we want to encourage you to keep on from that standpoint. And I'm just going to move through these studies real quickly, but here's just a nice study showing that exercise actually significantly, let me just move through this, improved how people walked, improved how they overall felt in it. So with that, let me just say that again, here's our center, things that, again, we think we are focusing on this in a variety of different areas. I think the areas that we can simply improve how people come. And with that, I'll stop and take any questions. Thanks very much for your attention. Sure. So I think that the question was, do we see these changes in the lung vessels? Do we see those in the heart? And are pains that are associated with this? Could this be chest pain associated with the pulmonary hypertension or with the heart itself? And so a great question. Actually, all our focus from a research standpoint, all our focus from a research standpoint here has been almost all of it has been on that vessel part, but how people do, again, it really focuses on how the right ventricle handles this pressure elevation. And I didn't have time to get over that today, but there's very great variation in that occurs. We're actually now turning our attention much more specifically on the right ventricle and how we might improve its function. Now, we don't see that same proliferation of cells, but there does seem to be something abnormal with the vessels that actually feed the heart itself in pulmonary hypertension. And so that's an area of focus. We don't know enough about it now. I just reviewed a bunch of grants, actually, that were very focused on that. So I think it's an area over the next couple of years we're going to understand a little bit better. Okay? But now to your second question, can that chest discomfort be associated? We very much recognize that as your pressures increase in your pulmonary, people can develop a chest pain. That chest pain can be a lot like left heart chest pain, angina chest pain. How much of that is the right ventricle under strain, how much of that is the pulmonary artery dilating is not entirely clear, but we do know that if we regress that pressure with a lot of these medications, a lot of times that pain gets better or goes away. But it can be very confusing when you hit an ER, for example. People go, oh, that sounds like angina, chest pain, but when we do our biomarkers, we don't see that, and that makes us feel better because at least it's not a heart attack, but it also lets us hone in and say, well, maybe your therapy is not where we need it right now. We need to up that. So. Yeah, so two more great questions and things we struggle with. So your first question is, does the right ventricle get damaged? To some degree, it gets big, it gets hypokinetic, but again, one of the things that, again, the beauty of this, why I'm so focused on the right side of the heart, is the amazing plasticity of the right ventricle, meaning that even though the right ventricle can look terrible, it looks like it's completely burned out, it's no longer functioning, if we can drop that pressure, the right ventricle is much more plastic than the left ventricle. That's why it's much superior to the left ventricle, in my opinion, is that it can shrink back down, it can be totally normal. The ultimate example of that is we can take someone who actually, when these drugs fail and we have to take someone to transplant, which still happens, though not near as often as it used to, once we've taken those lungs, we don't transplant the heart, we transplant the lungs. So we take out both lungs, even though the right ventricle looks terrible, we put in 2 new lungs. The right ventricle, within a matter of days, it's a really amazing thing, shrinks back down to normal, functions normally. The right ventricle is much more accepting, if you will, of this insult that it's had over a number of years. It says, I'm still with you, I'll stay with you, and it comes back down and works beautifully. How do we deal with the blood pressure? That's part of the art. We have to kind of figure out where your blood pressure is. You're right, all these medicines currently are vasodilators. We usually can work that out in a way that keeps people from getting too low a blood pressure, but that is part of what we have to struggle against. But this is where some of these new drugs are so exciting because they don't lower blood pressure. They really hone in on this pulmonary vascular bed abnormality. And so we should be able to add those on top of our pulmonary vasodilators and hopefully see dramatic improvement. So. Well, I think if this is a new pain for you, I want you to go in and be assessed for it because people can have both pulmonary hypertension and left heart discomfort. If this is pain that over time you've kind of figured out that this is my pulmonary hypertension pain, this is different, then usually usually when people get it, it's because they've increased flow. So we generally want people to kind of settle down, kind of take it easy, let that blood flow kind of decrease to that PA again. But then also alert your doc that this is going on because, again, now it may be time for us to adjust your medications to try to lower those pressures to let you do the things that you want to do, that is exert. So